Preventing Opioid Harms in Older Adults, Relief Plus video training series. Best Practices for Pain Management, Non-Pharmacological Approaches, Part 1.
I'm Nora Stern. I'm a pain educator from Providence Health and Services in Oregon, and I have a background in physical therapy. Patients living with pain, unfortunately, in a lot of places in Oregon and around the country, have only been offered medication, and so they've developed the belief system that medication was the only thing that could help them. So if you then tell them that you're going to take them off of their opioids and they have an old way of thinking about pain, that's incredibly threatening. You just created inadvertently an incredibly scary situation for a person who's suffering with pain.
I'm Dennis Turk. I'm the John and Emma Bonica Chair and Professor of Anesthesiology and Pain Research at the University of Washington. Most of the medications we have for pain, they rarely have been shown to have any improvement in functioning. So your pain got better, but you're not doing much. That's not a great success, okay? I want people to be able to function, do things, and that what they do is up to them. If they want to work in their garden, if they want to spend time with their grandchildren, if they want to go work in a library, I don't care. We have to find ways to help them keep doing those kinds of things and things that they want to do.
I'm Roger Chow. I'm a professor of medicine at Oregon Health and Science University. I'm a primary care doc. I also direct the Evidence-Based Practice Center at OHSU, and I was one of the lead authors on the 2016 CDC guideline on opioids for chronic pain. Older adults have special unique considerations. They may have cognitive difficulties, which can make assessment of pain and management of pain a challenge. They're often on a lot of other medications, so the polypharmacy can be an issue. The cognitive component is very important because that can be a major challenge in terms of both assessing older adults with pain as well as managing pain safely and effectively. Our focus in the CDC guideline has been on getting away from pain as the sole kind of main outcome, and that we really want to look at it more globally with a big emphasis on functional improvement. And we are able to address that with some of our therapies like cognitive behavioral therapy, functional restoration, exercise therapy. All of those things can help people get back to their function, even if they still have pain.
Alternative therapy is a term that makes it sound like the primary treatment one would use would be opioids. In fact, in the past, there has been use of the term pain management as a euphemism for opioid prescribing. And we can see many, many reasons why that is really a dangerous thing to talk about. In fact, the treatments that fall under the term alternative therapy are actually best practice pain care for complex pain. So behavioral health, rehab, physical therapy, occupational therapy, yoga, mindfulness practice, cognitive behavioral therapy, those should be the first line of treatment for complex pain. So we should be considering those to be best practice pain care, not alternative therapies. And opioid management should be called opioid management.
I'm Jim Shames. I'm a family practice physician. I'm also the health officer for Jackson County, Oregon. I'm board certified in family medicine as well as addiction medicine. I think we need to realize that chronic disease management, pain management in particular, can't be managed by just the provider alone. We need lots of resources. We need peers to help support patients who are fearful to move and fearful to engage. We need to engage people who do movements, yoga, physical therapy, to teach people how to start using their body again. They need behavioral support. They need all sorts of support, which we can't provide in our 15 or 20-minute appointment. So it's a team effort. I think we need to talk to our colleagues, figure out who those resources are in our community, and bring them in. And I know all the standard disclaimers, insurance doesn't pay for it. Well, they really are starting to pay for it, and you need to push back. If you demand that they pay for it and your partners demand they pay for it, they will start paying for it. The patients are resistant, of course. They come around and they'll often thank you for pushing them in the right direction. So you can solve these problems, you just can't solve it by yourself.
One patient I have that I can think of has chronic back pain. She actually came to me on very high doses of opioids as well as benzodiazepines. She has a number of other medical conditions, including avascular necrosis of the hips and shoulders requiring surgery. So she came to me on very high doses of opioids plus all these other medications. But she was still in quite a bit of pain and not very functional at all. So I've been working with her over the last couple of years, getting her into physical therapy, working with her on her coping strategies. She's done some formal cognitive behavioral therapy and has also done some work on her own. And we've actually been able to titrate down her opioids from very high doses. They were initially close to 700 milligrams of morphine a day, down to about just over 100 milligrams per day. You know, she sometimes has flares of her pain that we need to work through. We have gone up temporarily on the opioid dose, but the trend, you know, has always been down, and she's actually been doing quite well. You know, her pain is not better, but it's also not worse. And she feels like she's functioning better and she's not having as many side effects from the opioids.
Discussing referrals and recommended treatments.
My name is Joyce Schoberg, and I am an aging life care manager. My background's nursing, graduated from OHSU, and I own Aging Advisors. It's a local aging life care management company here in the Portland, Vancouver area. Yes, there's often convincing that we have to do with older adults when we're looking at other strategies outside of medicine or pharmacies. And oftentimes I go back to those original communication strategies I mentioned with humor and joke about, well, you know, the pills can't do it all, so let's try some other options. Wouldn't you agree that sometimes you have to try a mixed bag of tools or techniques and drawing analogies to approach that person?
Everybody my age I know has got pain, whether it's your knee today and your hip tomorrow, or, you know, or your back all the time. And there are strategies. There's health promotion strategies. There's exercise and stretching and staying active, and don't let the joint get immobile.
My name is Laura Hesacker. I'm a licensed clinical social worker. I work with Jackson Care Connect as a behavioral health innovation specialist, and I work with the Oregon Pain Guidance Group. Motion is lotion, right? I mean, beginning to sort of build these things into their repertoire for patients to hear it's safe to move, it's good to move, even if you experience discomfort. Even breaking that down with a patient, there's pain and there's discomfort and there's, concern, and helping a patient sort of discern those different things, I think can be really valuable and so important if you're going to send your patient, say, to physical therapy.
One of the biggest fears, as I've talked to some older pain patients and older people in general, is fear of falling. And what the fear of falling is really related to is fear of an injury that means I'm going to lose my independence. And therefore, the provider needs to be aware that that may be going through the patient. And so, you want me to be more active, but if I'm more active, it could increase the chance of fall. And therefore, I don't want that to happen. Well, if that's going to possibly be a thought of the patient, you bring it up with them. And that's when the idea of pacing and gradual activities and setting realistic goals. You're going to walk around the park. You're going to walk down the street. You're going to walk in the mall. You're not going to mountain climb, okay?
You're trying to encourage the patient to go to physical therapy, go to a yoga class, go get some counseling, go to a grief counselor, and the patient may be telling you all the reasons why that's not going to work. What we know for certain patients living with chronic pain is that for whatever reason, there's a certain amount of sort of catastrophizing that happens. And so this can, what a provider might be looking for in a patient and being curious about is catastrophizing part of the challenge. It could be like all or nothing thinking, right? Or, I'm having this pain, so for example, I'm never going to be able to work again, right? And so I think that for providers to be able to identify that's sort of bring awareness to that. Like, I'm hearing these things come out of you, and be able to sort of use that idea that the brain is sort of saying this, the mind is saying this as a way to try to keep you safe. And the reality is, you getting out there into your life is actually going to be what's going to help your chronic pain. You engaging in things that are important to you, that are meaningful to you, even though your mind is saying, this is really scary, this is never going to work, I'm never going to get my life back, that to sort of act in opposite of that. At times, like teaching a patient to act opposite of what the brain or the mind might be telling them.
There's a lot of fears and a lot of misunderstanding about what pain is. And there has been discussion about the idea that there's actually a lost generation of people who will never be able to go off of opioids. And I don't know that we have a right or wrong answer about that, but I do know that the nervous system is tremendously capable of change. So the idea that a person would not be able to turn that ship around, it just doesn't jive with everything we know about neuroplasticity. So if it's 20 years on opioids, it might be a tanker, but you can still turn it. It's going to turn slowly. And your job as a clinician working with that person is to be their coach and to be their cheerleader and to give positive reinforcement for every single gain, no matter how small, and not to forget, for example, if you started to talk with somebody about beginning a walking program that started with 5 minutes and they come back to see you 2 or 3 weeks later, you got to ask about the walking program. You got to ask about that before you ask them about their pain. In fact, it's very important to talk about pain in relationship to function.
Promoting sleep and nutrition.
My name is Mary Schiff. I'm a patient advocate, and I'm also a chronic pain patient. There's some primary, really important questions that you have to ask a patient. Are you sleeping? That's a big deal for older people, and I'm glad I thought about it, is sleeping. How are you sleeping? What are you taking for sleep? Really important. Therefore, are you a fall hazard? What are the resources in the community that we can get somebody in to evaluate your house? But I think sleep is a really big issue that needs to be discussed with primary care providers and the patient.
My name is Michelle Maricos. I am a peer support specialist and person living with chronic pain. So sleep is the #1 complaint of most people living with chronic pain. They don't get good sleep, they don't get quality sleep, and sleep hygiene is really important to go over with patients, especially older patients, that none of us actually learn how to sleep properly. So it's really nice to be able to have a few tips and tricks about sleep, that a cooler room is really helpful. It helps patients actually go into REM sleep and get better quality sleep. To prepare their room, to actually turn off electronics if they do use electronics, turn off the TV, do not sleep with the TV on. Many older people do sleep with the TV on, and that just becomes habit. That actually can deter them from getting good quality sleep. Drinking different chamomile teas, that is really helpful. Drinking warm milk with cinnamon and nutmeg. Sleeping without pets is really important. We love our pets, and older people love their pets, but pets can be really disturbing to sleep.
A person might not identify on a shared decision-making tool that stress is a big part of the puzzle, but that might be because they're not really ready to address that yet. But they might be willing to look at their sleep, and their sleep is going to be a window into quieting their sympathetic nervous system, because if they quiet their sympathetic nervous system, they will sleep better. Or they may identify that they'd like to get back to moving. And as they start to understand that pain and harm are not the same thing, that they can start moving and thinking about being sore but safe, as they become more active, they will then sleep better. And as they sleep better, they will feel less distressed in their life. And then they may be open to thinking about stress reduction, counseling, meditation practice, etc. So there's many avenues in, and you don't need to do them all at once. You work with the thing that is the most important for that person. That's the road in. And you can begin there, and it's a long process. It was a long process to get into the pain that they're having, and it's a process to get out of it.
The role of nutrition in older adults, I think, is really crucial too. We do both when we're assessing an older adult. We talk about both their routine and when they're getting their meals and what type of food they enjoy, what they don't enjoy, what their allergies are. And looking at a year ago, 6 months ago, what were they weighing? What was their height? We look at their average body weight, so we kind of know where we are and where that person is with that. But when it comes to pain, we have noticed, and we're certainly reading a lot more in literature, the information that's being presented to us around the connection between diet and pain. And so we do make a lot of recommendations for people to consider the use of anti-inflammatory diets, Mediterranean diets, or other similar diets.
My name's Jennifer Hess. I've been a chiropractor for 28 years, and I'm also an associate professor of research at the University of Oregon. Reducing sugar in your diet is a very important way of reducing inflammation in your system. And inflammation causes a lot of pain, muscle pain, aches and pains, joint pain. So when I talk with my patients about nutrition, I try to promote a diet that's high in fruits and vegetables, in particular green leafy vegetables, lean meats, fish, omega-3s, and in particular reducing refined sugar from the diet. And having a diet that follows sort of a Mediterranean type of diet like that is going to help reduce inflammation. That's going to help reduce aches and pains and soreness that frequently come with chronic pain.
One of my peers called up and said, my mom has pretty advanced osteoarthritis, and we're looking at potentially having to move her because her pain is so bad. She can't open her pill bottles, she can't hardly hold on to silverware and feed herself, and her joints are just giving her so much trouble. And I said, well, how bad does she want to stay in her home? And she said, pretty bad. What are you asking? And I said, well, is it bad enough for her to try to change her diet? I said, because the literature is showing for those people who are really wanting to commit to it, these diets are making huge strides in their pain. She called back 3 to 4 weeks later and said, you can't believe it. My mom is doing so much better. She really is finding that it's making a huge difference, just cutting out some of the foods in her diet and assisting her in pain. So I think there's a real connection there, and one that we're going to learn more about over the next few years as well.
The things that we know as being the key domains of best practice pain care, knowledge of pain, sleep, good nutrition, return to activity, and mood, those interventions have all been available to us all this time.
Setting realistic expectations for non-pharmacological care.
Cognitive behavioral techniques or interventions is a whole range of different techniques that people can use. Common techniques you'll hear about are cognitive restructuring. What the heck does that mean? Cognitive restructuring means helping people understand the importance of their thoughts, and they may be maladaptive. If I worry about every time I move, it's going to make things worse, so therefore I don't do anything, I'm going to become more physically deconditioned. I'm going to do less, more things are going to be difficult. So therefore, thinking affects the behavior, which can contribute to more of the pain. The treatment techniques from cognitive restructuring are trying to say, how do we help people become aware of those thoughts, to be aware of the impact they can have? And cognitive behavior, when I talk to primary care providers, it's almost a euphemism for psychological. And that's not what it should be. It's a perspective, and it's a set of different interventions, skills, information that you provide to a person to help them. We want to move the person from being passive, reactive, and helpless and hopeless to being active, resourceful, and in self-control.
So when you refer a person for chiropractic care, they will receive a initial examination, evaluation. The doctor may order x-rays or lab work if that's appropriate, or they may refer you out for other types of diagnostic tests. On the initial visit, the chiropractor may or may not perform a chiropractic adjustment, and the chiropractic adjustments will be safe and effective for each patient. If it's an older adult, a more gentle adjustment will be used. Chiropractic care is effective for treating all kinds of neuromusculoskeletal disorders, such as strains and sprains, headaches, neck pain, low back pain. Chiropractic is very effective in treating low back pain. Whiplash after a car accident or any kind of acute injury, as well as chronic injuries. Chiropractors are healthcare providers who go through 4 years of graduate clinical training and are licensed by their state. Chiropractors take national boards as well as state licensing boards.
So physical therapists are specialists in movement and function. We can work with a person on return to activity, and we can analyze safety aspects of balance. We can look at strength, range of motion, and the different things that might be barriers to a person being able to safely get back to moving, and then coach them through that process. So physical therapy has changed a lot over the years, and if you've had an experience in the past that you didn't find helpful, it should be very different now. And I also want to remind you that as you get back to moving, you will have discomfort. You may have some pain. We don't want to make you very painful. We want to avoid flare-ups if we can, but realize that the flare-up itself is not harming you. It's just a sign that your system has gotten a little too good at protecting you. So the physical therapist will be working with you on a slow, gradual return to activity. And I'm here to coach you and to support you. And I want you to remember that you will have discomfort, but pain and harm are not the same thing.
If I was talking to a patient and I said to them from a cognitive behavioral treatment, said, so now that you say you're feeling a little bit better, my next question to them is, what are you doing now that you weren't doing before? Because now I want to start seeing that you're actually doing things. We all cope all the time. But the question is, are you using the skills you have? And are there some maybe I could teach you to engage in?
The first appointment with a chiropractor is usually the longest visit. It would start with a detailed history. I would sit down and talk with a patient about where they're hurting and try to get at some of the root causes for pain, whether it is, especially chronic pain, whether it is an injury that happened a while ago, or it could be too many hours at a computer, too much time reading, or in older adults it might be a hobby like knitting, something like that. So we want to find out what those root causes are. Then I would do a comprehensive examination that includes checking vital signs as well as evaluating the musculoskeletal system. So I'm going to look at ranges of motion, I'm going to check reflexes, I'm going to palpate muscles and find out exactly where the pain is. And then after that, I would talk with my patients about what I found and then what my treatment plan would be, what kind of care I want to do. Do I want to just do manipulation, or do we want to have other aspects of treatment such as exercise therapy or soft tissue care, things like that. And then I would lay out a treatment plan for my patients, how many times I want to see them, what my expectations would be in terms of care, what I'm looking for in terms of their subjective complaints and my objective findings.
So when you go to physical therapy, your physical therapist will get a history so they understand what you've been dealing with and fully understand some of the previous things that you may have done to help yourself as they build kind of a picture of your whole history. And then they will go through a physical examination, and they'll be looking for things like strength and range of motion and balance so that they can see where some of the factors are that are limiting your ability to do the things that you want to do and where they can begin to intervene. We're more likely in working with complex pain to first focus simply on a slow progression back to activity and thinking about getting moving in a more general way rather than starting an exercise routine, because the idea of an exercise routine might feel kind of overwhelming to somebody who's been really inactive. And what's really important is for them to simply get engaged. So we can help with the gradual pacing to return to activity. We can work with something called graded exposure in return to activity, where we look at all the different pieces of the puzzle, like in moving from lying down to sitting to standing. We can look at the environment that a person's in. We can look at whether a person is turning and twisting, whether they're using their whole body or one part. We're working with people on focusing on doing the movement smoothly and easily, in rhythm with their breath, simply getting back to moving rather than focusing on exercise, and helping people tune back into sensing their body in terms of sensations that they feel in addition to pain.
When a patient comes in to see a therapist or a provider, he or she, the provider, can tell people, well, that was good that you did this, you did that well, I'm glad to see you're trying that. So it's a reinforcement. It's an external reinforcement. That's good. It's important. But most of the time, people are not in my office. They're out there functioning. So I want them to learn to self-reinforce. And how can you self-reinforce? Well, I want them to learn to monitor their own behaviors and activities, to see what they're doing. And actually, we have them keep charts, right? I encourage them to keep charts. So there's the changing the thinking, there's looking at what skills they have, teaching them new skills, practicing or rehearsing those skills, and then planning on anticipating, worrying about maintenance and generalization, because if they don't maintain it, what do we know about people who go to weight loss programs or smoking reduction programs or alcohol programs or stroke rehab programs? What happens is when they're in the clinic, they can do pretty good. And then they all relapse. Okay, what are you going to do when it happens? And what do you do to prevent yourself from totally giving up? Okay, that's the goal.
Pain has a reason for existing, and we need to pay attention to it, but we don't need to be ruled by it. And as we get older, parts of our body do hurt. And I like to think of it as a message to me that I need to be moving around more when my back is hurting, rather than I need to stay still and go to bed. So I think we need to reimagine what the pain means for us and what its purpose is. We're not going to be able to live a life that is pain-free. I think people that are expecting that are probably heading into trouble. Pain is with me. It's a part of me. I'm going to manage it. I'm going to control it. I may need to take medication occasionally. I can't sleep because my pain hurts. And you may need to take opioids occasionally. But for non-malignant conditions, by and large, regular opioids are not a safe way to approach pain management.
Preventing opioid harms in older adults. Visit healthinsight.org/relief-plus for resources related to the topics discussed in this video. This material was prepared by Health Insight, the Medicare Quality Innovation Network / Quality Improvement Organization for Nevada, New Mexico, Oregon, and Utah, under contract with the Centers for Medicare and Medicaid Services, CMS, an agency of the U.S. Department of Health and Human Services. The contents presented do not necessarily reflect CMS policy. 11 SOW-OSSIP-18-05-OR